So my name is Zara. I'm one of the doctors in the Council of Chester Hospital in the UK. I'm going to be talking about some novel therapeutic applications that we have for SGLT2 inhibitors. So I know that there's a lot of different backgrounds in this conference. So I'm just going to explain a little bit simpler and just go through the introduction as to what these medications are, what they're used for, and what do I mean by novel therapeutic applications. Um, SGL2 inhibitors are basically a group of medications, a class of drugs that were initially developed for glycemic control in type 2 diabetic patients. They are inhibitors, selective inhibitors of sodium glucose cotransporters in the kidneys, and therefore they reduce the glucose levels in your blood, which is why they were developed for type 2 diabetic patients. But new research has shown further benefits for cardiovascular problems as well as kidney functions. So they've seen that they reduce the overall heart failure hospitalizations and slow CKD progression as well. CKD is chronic kidney disease. There are several guidelines that, as we know, will promote the use of SGLT2 inhibitors in patients with diabetes, the ones with chronic kidney disease and heart failure, as well as patients, newer guidelines that will sponsor the use of these medications in patients without diabetes, in patients with heart failure and chronic kidney disease that don't have a hyperglycemic problem. There's also several new emerging uses for these medications, including metabolic associated dysfunction of the liver, so steatosis, and obesity, gout, and PCOS, but these are used off-label, and I will get into that a little bit later on. So like I said, they were initially developed for type 2 diabetes. They are selective inhibitors of the sodium glucose cotransporters in the proximal convoluted tubules in the kidneys in the S1, S2 segments, and they reduce the renal glucose reabsorption and promote glycosuria and reduce the serum glucose levels. Initially, canagliflozin was the first one to be approved in 2013. This was then followed by dapagliflozin in 2012 and 2014, and then empagliflozin in 2014. They were initially developed to reduce the glucose levels in patients with type 2 diabetes that were not being properly managed with diet and lifestyle interventions. They were seen to have a modest effect on reducing the HbA1c with a 0.6 percentage reduction, and they had good benefits on the reduction in weight and blood pressure as well. But they were also seen that they had some effects on cardiovascular protection as well as the kidney function and protecting patients, non-diabetic patients, for their kidney disease as well. So there were several trials that we will get into. The first one is the EMPEROR Reduce trial that reviewed patients with heart failure with reserved ejection fraction, and it's been seen that there was a reduction in the cardiovascular death, as well as the number of patients that were hospitalized because of heart failure. The EMPEROR Preserved and the DELIVER trial looked at patients with a preserved ejection fraction and moderately reserved ejection fraction, and saw similar benefits as well. There were a reduction in the number of hospitalizations with patients with heart failure. A recent meta-analysis of over 90,000 patients also saw a reduction in heart failure associated hospitalizations, reduction in all-cause mortality for heart failure, and this was seen in all spectrums of ejection fractions for these patients with heart failure. However, it's important to note that the studies that were done were on patients with heart failure and not necessarily the patients with atherosclerotic events, so patients with risk of coronary artery disease. More studies need to be done to investigate atherosclerotic diseases in heart failure and how in the heart disease and how SGLT2 inhibitors can protect them. There is evidence of protection, but there needs to be more research done on this. Like I said, kidney protection as well. So SGLT2 inhibitors were seen to have renal protective effects. They reduced the slower decline of the eGFR and slowed the reduction towards kidney failure. They slowed up progression of chronic kidney disease and reduced the albuminuria as well. It was seen that in patients with chronic kidney disease with an eGFR of less than 60, there was a 30% reduction in adverse renal outcomes. And this was done by reducing the intraglomerular pressure, reducing the protein loss and the albuminuria in the urine, as well as exhibiting some anti-inflammatory effects. Overall, obviously, safety is very important in these patients. They have a good safety profile. They reduce the progression of heart failure and chronic kidney disease to no specific expense. We do have some risk of genital mycotic infections, and in some patients, in about 0.1% of the population in our studies, there were some risk of euglycemic diabetic ketoacidosis. But this was pretty rare. There was no increased risk of AKI, and in most patients, it was evident that actually the use of SGLT2 inhibitors were protective against the development of an AKI. However, we do have to follow the sick day rules and the perioperative rules as well. So before operations, and if the patient has developed an infection, these medications need to be suspended. So, to get into their benefits, I will just go through the mechanism of action for these medications. So, like I said, they inhibit the sodium glucose transporters in the proximal convoluted tubules and therefore reduce the glucose reabsorption and promote the loss of glucose and sodium in the urine. They promote glycosuria, natriuresis, and they have some mild osmotic diuresis as well. The cardiorenal benefits is that of beyond glucose lowering, they reduce the interglomerular pressure through the tubular feedback. They reduce the loss of proteins and albumin in the urine and have some modest reduction in the body weight as well as blood pressure. They furthermore reduce the serum uric acid levels and insert some anti-inflammatory and antifibrotic effects. Therefore, this explains the hemodynamic and the renal benefits. By the diuresis and the initial natriuresis, they reduce the plasma volume and reduce the blood pressure. They restore the tubular feedback and reduce the intraglomerular pressure. There is, when we start somebody who's naive to SGLT2 inhibitors, there is an initial dip in the eGFR, but then this decline tends to slow down and reach a steady state, and there is a steadier progression of lack of progression basically towards a chronic kidney disease. They do tend to also have some effects on the sympathetic nervous system, but this again needs further studies to be done. And the metabolic effects is also very beneficial. So we've seen a shift from a glucose utilization state to a lipid utilization state, and this is done because of the loss of the glucose levels in the urine. We have a shift from towards hepatic ketogenesis and increase in levels of serum ketone levels, more specifically beta hydroxybutyrate being the main source of energy for the cells, and therefore we have decreased insulin secretion from the pancreas and increased insulin sensitivity, and therefore we have an increased peripheral glucose uptake by the cells reducing the glucose levels in the serum as well. And finally, we have the anti-inflammatory and anti-sclerotic effects that were very well studied. So we have a suppression of the inflammatory response, moderate. We have a suppression of NFK beta and NLRP3 inflammasomes. We have a decrease in the inflammatory cytokines, being the interleukin-1 beta and TNF alpha. They modulate the innate and adaptive immunity, and there is a shift towards M2-like phenotypes in the macrophage cells, and which dampen the T cell effector activity, so reduce the general inflammatory response. We have a decrease in oxidative stress and increase in NO bioavailability, and this means we have some endothelial protection, which is why it is important to study these medication uses in atherosclerotic disease to see whether they can be further enhanced in the usage of these medications in coronary artery disease. But again, because they suppress your immunity, we have to follow the perioperative management rules and the sick day rules because of the increased risk of mycotic infections. So, like I said, we have some emerging therapeutic applications for SGLT2 inhibitors. We saw that in the Emperor Preserve trial for heart failure with preserved ejection fraction, empagliflozin reduced the cardiovascular death and heart failure hospitalization by 21% in patients with diabetes, and it's also seen in patients without any hyperglycemic control, so with or without diabetes. The Deliver trial saw that the dapagliflozin had similar effects for heart failure with preserved ejection fraction, irrespective of the diabetic status. Internationally, we have the ESC 2023, and in the UK, we have the NICE TA 9029 and 929, which recommend SGLT2 inhibitors for heart failure patients despite their diabetic status. So we are moving towards a shift from diabetic control to patients with heart failure without diabetes. We also have it in metabolic dysfunction associated allostatic liver disease. So we've seen in the meta-analysis that we have a reduction in the liver enzymes. We have a reduction of ALT, AST, gamma GT, hepatic steatotic markers, and we have some decrease in hepatic fat content, as well as fibrosis on the fibroscans in patients with or without diabetes when we use SGLT2 inhibitors. So they do have some hepatic protective functions, but they are not yet fully licensed for use and require further clinical studies to be done. Very interestingly, we have them in gout and hyperuricemia because, like I said, they reduce the serum uric acid levels, especially dapagliflozin 10 milligrams and apagliflozin 50 milligrams. They were very effective in reducing serum uric acid levels in the meta-analysis, which means that then this is done by modulation of the GLUT9 transporter and the urea transporter 1 in the kidneys, and this is done by glycosuria and natriuresis as well. So we lose serum uric acid levels, which means that we have fewer flares in gout and overall decreased mortality seen in gout patients. Again, this needs further studies, but there are some smaller trials that have focused their studies on this subject. And we have PCOS as well. So because there's no direct effect on the number of follicles and the number of cysts in your follicles, however, And it has been seen that does reduce the symptoms and the syndromes that we have associated with PCOS by improving the BMI and the insulin resistance. They decrease the androgen levels, including the overall testosterone levels and the free androgen indices. And but again, this was seen in smaller studies, and there is larger studies ongoing at the moment, focusing on the use of SGLT2 inhibitors for specifically for PCOS. So the current guidelines, we have the NICE guidelines in the UK. We have several of them for both diabetic and non-diabetic patients. The NICE NG28 and QS209 recommend the use of SGLT2 inhibitors in patients with type 2 diabetes and chronic kidney disease, together alongside with medications such as ACE inhibitors that are going to have some renal protective factors. And the dose of them is guided by the amount of protein in your urine, so ACR of more than 30. They also support the use of SGLT2 inhibitors with patients with type 2 diabetes who have chronic heart failure. The TA 679, and 773 recommend the use of SGLT2 inhibitors in heart failure with reserved ejection fraction despite diabetes, despite any hyperglycemic problems. TA 902 and 99 recommend their use in preserved ejection fraction and moderately reduced ejection fractions, again, despite diabetic status. And TA 1079 is specifically for chronic kidney disease with or without diabetic problems. So we are moving towards a state where SGLT2 inhibitors do not depend on the diabetic status, and we can use them for heart failure across all ejection fractions together with chronic kidney disease. And we have some international guidelines as well. The ESC 2023 recommends the use across all heart failure ejection fraction spectrums. The ADA 2025 recommends it for heart failure and chronic kidney disease despite diabetic status. And the KDIGO 2024 recommends the use of SGLT2 inhibitors for chronic kidney disease with or without diabetic problems, with an eGFR of more than 20 and a significant albuminuria of more than 200 in the urine. So future directions looks towards expanding the usage of the SGLT2 inhibitors above diabetic control. Obviously, we have some shifts towards the use of chronic kidney disease and heart failure, but it will be even further than that with PCOS, obesity, gout, and static liver disease. We need to start incorporating this into primary and secondary care and observe their overall side effects and potential outcomes in these patients as well. So in conclusion, the mechanism of action of SGLT2 inhibitors is through osmotic diuresis and natriuresis, and they have some hemodynamic unloading with reduction in the preload and the afterload in the heart, and improve the energetics and the metabolic effects in our systems. They are currently guidelines recommend both nationally and internationally for the use of SGLT2 inhibitors in patients with diabetes, in patients with heart failure and chronic kidney disease despite diabetic status. Further usage of them would be in patients with PCOS and liver steatosis, as well as some level of hypertension and weight control despite diabetic status. But these are very primary studies, and further studies need to be done, especially in managing the overall outcomes of the patients and to look for any side effects that can come from the use of these medications. Okay, thank you. If you have any questions, let me know.